Thank you for waiting so patiently. Hi everyone, I'm Wenyi. I'm a nurse injector. And I'm really excited to be here. And so many familiar faces. All of you are very experienced in this field, so it's really my privilege to present in front of you. Malcolm Gladwell said, natural ability requires a huge amount of time in order to be made manifest. And it is true within our field because all of us that works a long time in this field, we have gained so much experience and it becomes part of you. And I've worked 8 years in this field and it's really taught me so many things. And I'm gonna start. And just a quick recap of what I have achieved in the last few years. Quick recap on the cross-linking technologies, particle-based, gel-based, and also the RHA is both particle and gel-based, so then it gives you the better result because it's cohesivity, good lift, and also great shape. This is under 25 times magnification, and you're able to see for the particle-based filler, it's very loose and it's great for shapes and peaking. And on the other side, you have the Vycross product where it's jagged surface because it's a low molecular weight. And in the center, we have the RHA4. You can see that it's a larger particle where it's loosely cohesive. From the past, whereas the first generation of fillers, we focus on the G prime, which is the lifting capability. Now we've moved towards the stretchability of a product because we want to maintain the face's natural expression as we talk to people and for those people that don't want people to know they had anything done. I wanted to touch up on a landmark study. This is by Rorik and Pesa. Previously, in the beginning, we always considered aging as a gravitational descent. But actually, by 2007, this landmark study was able to indicate that not only it's gravity, but when we age, it's aging at different levels. The deeper compartment of fat and the superficial compartment of fat, they're not intermingled. They're actually completely separate layers, and they go through a different morphology. They have different mechanical properties. And in real life, you can see as he ages, the lateral component of his face, it's a clear demarcation of the deep buccal fat aging, whereas the superficial fat has effectively moved forward and fat displacement. And an overview of the superficial and the deep fat compartment. Okay, and this is actually the patient that I'm going to treat today. I just wanted everyone to look at the pre-photo before I treat, so then you can get a better sense of what the result will be after we finish. Is a tear trough a standalone entity? Because when we learn more about the deeper fat compartments, we actually realize most of the creases that we see is displacement of fat rather than a decrease in volume. And laterally, with some guidance, you can see the superficial fat compartment plus the deeper fat compartment. And in my patient, you can see the temporal hollow as well as the body of the buccal fat depression. And this is why you see the corner of the mouth slightly sagging. And we all know the aging also occurs on a bone level. The orbital rim widens. On a muscular level, you can see the superficial fat and the deep fat. So going forward, when I'm injecting this patient, the vasculatures that I will be looking out for are the temporal artery and temporal veins, as well as the zygomatical orbital artery. And of course, taking into consideration, we don't want to damage the temporal nerve. This is actually one of the most important studies that I came upon that I wanted to share with you today. The study is called the facial adipose tissue revision. So like I said, at different level, at different depth, at different compartments, the fat are actually not exactly the same. This author, Dr. Kuklikov, she has divided or classified them into 3 different facial fat. There is a deposit type, which is a non-lobular adipose tissue that is mostly in the deeper compartment of the face. And as we age, you see this compartment decreasing. It's the first compartment that decreases with volume. It has large adipocytes and it has very weak collagen connection, very loose, almost non-attached. There's no fibrous tissue holding them together. There's a second type, which she defined it as the structural type. An adipose tissue, which is a large adipocyte, but is covered with a thin layer of fibrosis. It has a fibrous shell and it's able to maintain its shape. And then there is the last type, which is the smaller adipose tissue covered by a thick layer of fibrous shell. Because of these physiological differences, the mechanical capability and the aging process is also different. So taking that into consideration, you would know when you're using a filler into that direct compartment, you have to use a filler that is similar to whatever that is originally there. Lastly, I also wanted to touch upon an important point, which is the aquaporin 7. The extracellular matrix of, well, in a fat cell, there's about 20% water. And in the ECM, it's about 17. Inside the cell, it's about 2 to 3. When you inject hyaluronic acid into the fat, it increases the hydration content of the fat. And in a way, now the fat has to regulate itself because it's in a highly hydrated environment. And it would decrease its aquaporin 7. And this marker actually is what causes lipolysis. So when you increase the water content of a fat tissue, and with the reduction of aquaporin 7, we have actually effectively decreased the fat loss. So not only you're injecting a filler, you're prolonging their fatty compartments and delaying the aging process. I thought that was fascinating. Another study that I really wanted to share with you is a longitudinal analysis of the superficial midfacial fat. This is a CT scan following 15 subjects over 10 years. And the result of which is the doctor were able to produce a result that says what we see in sagging in the superficial fat compartment is not a decrease in volume, but rather a displacement. And this would tell us when we inject, we want to control how much product we put in the superficial layer because the volume actually remains the same. Rather, we want to focus our injections in the deeper compartment because that is what is going to give you the lift. And I wanted to put this on here because I thought that was really incredible that Teosyal not only back in the day were able to produce products that were strong and cohesive, it's able to lift and stay in the shape, but it also responded to the market because now we're moving towards stretch. And you can see the RHA1 has the highest stretchability with the lowest strength, and then on the other side we have the RHA4 that has the highest strength and the lowest stretch. And combining with the information that I just presented earlier, knowing that your fatty compartments are actually mechanically different around the mouth, it's more fibrous, so we're going to use something that is more stretch. And in the deeper compartment, knowing that it's loosely connected and it's a deposit type, you can use something that would open easily, such as number 3. And then also in the buccal area, the buccal body of the buccal fat, when you have volume loss, I usually recommend using 4 because you can not only use it as a volume to open up the area, but you can also provide support for the zygomatic major, zygomatic minor, and in a way it lifts the face. Today I'm going to be using RHA3, a depot injection, and then I'm going to use RHA2, which is a superficial, well, between fascia. I would be injecting lateral canthal. And if it doesn't improve enough, then I will move on forward to the tear trough itself. And I also wanted to touch on the point that back in the day, we've always focused on treating the cheeks. But now knowing that it's the deep facial fat compartment that are actually changing, perhaps moving the treatment towards treating the deeper facial fat compartment first could benefit us to create a more natural result. Thank you. So generally, of course, prior to injection, we always sterilize the area. I like chlorhexidine, but the other day I was just pointed to that we should always ask our patients to close their eyes because it is toxic to the membrane. So close your eyes and I'll clean you again. And I'm gonna be doing a depot injection with RHA3, and it's over here. So before I start, I always like to mark, just because somehow it helps me. It's became a part of my habit. And actually, because when patients sit and then when they lie down, some of the facial fat actually moves too. So it's a good idea to actually have them sit up straight more and then have them lie down. In this position, I think she is good. And of course, we're going to palpate for that bony marking, that temporal line. And I know we've been taught that we say 1 centimeter over and 1 centimeter down, but not everybody has the same vasculature. I've had cases where I put my finger there in that 1 centimeter zone and I feel a strong pulse. So of course, always check your site, just knowing that probably the thinner area closer to that borderline is safer, just because it's a more superficial point for your needle to get to. And I'm also going to mark out the lateral canthal hollow. It's strange when I'm injecting, I find such peace. How many of you feel that way about injection too? Okay, RHA3 primed. Again, I put my finger here. I wait and stretch the skin. I anchor my needle on my other hand, straight in, and then I tug a little bit, and then I aspirate. Nothing, and then I inject. And at any point, if you feel a pressure pushing back, you should stop. And that's half. Done. Facing forward, you can just see the difference between the two sides. So because I'm utilizing that deeper fat compartment, it's traveling downwards. But of course, this is the old technique. Everybody's seen it before. So this is just to prime. And I'm gonna go on to the other side. Okay. Yeah, it's okay, relax. And what I find also helps with this type of injection is sometimes waiting a little bit longer helps, because when the patient gets nervous, you really feel that pulse. And of course, then it's safer because you know what to avoid. Okay. Stretch the skin, anchor the needle, 1, 2, 3. Tug, pull back, and inject slowly. And notice how I keep my finger around this area, because if I'm close to a vessel or if I'm exerting too much pressure, then you would really feel that vessel bouncing at you. Then that's a sign you should maybe slow down or stop. Okay, 1 syringe complete. And now I'm moving on to RHA2. With this injection, I use a 25 gauge cannula. I would do, depending on how the texture of the tissue feels. Sometimes I go under the ligament because I want to utilize that orbital retaining ligament to lift the orbicularis oculi. Sometimes when there is too much hollow lateral canthal, I go above the muscle to create a continuation. So then she doesn't have that peanut shape on the temple area. And I think so far when we have corrected the deeper compartment that she's already seen, we've already seen a good amount of improvement. I like to use a shorter cannula so I have a little bit more control over the area. Over the cannula itself. And we know that there is a zygomatical orbital artery and vein traveling this way. Supporting the orbicularis oculi. We know that the temporal nerve travels up this way. Of course, everyone's physiology is different. I've been to conferences where the physician prefers to make an entry from the top, but I find that way I feel too much resistance. Even though I'm trying to get in between superficial fascia and the deeper fascia, I find my entry point closer to the CK4 is much easier. So I'm going to start here. Turn this way. And it helps, sometimes we can stretch the skin and see if we can maybe even visualize the vessel before we introduced. Okay, 1, 2, 3. Thank you. I like to pinch the skin to create a pillow for my cannula to go in, and there we are. But I want to reach to the higher point, so I actually lift the skin up, keeping the hair out of the way, and I do feel resistance. I'm gonna pull back, inject a little bit, create a little bit of space for my cannula to move on forward. And I actually do aspirate when I'm using cannula too. It's just a force of habit. And the tip of my cannula is actually over here. So this is why it's called connecting the temporal hollow to the lateral canthus. And then I redirect, moving towards the lateral canthus. This is over right at the border of the orbital bone. And you don't want to do too much over here, because then sometimes it creates a false appearance of the lateral orbital ligament thickening. And I look from your angle. It's okay, stay where you are. Yeah. From your angle, you can probably turn your face that way. You can probably even see that there is still some temporal hollow over here. Again, I redirect. Creating some space. Creating a continuation from the temple to the zygoma. Okay. And injecting in this area helps when you're putting in a little bit at a time, because it helps to open that space up. It is a fanning motion. It is also a small droplet. I am between fascia, so which means when I was injecting, you feel the resistance first, and once the cannula goes through that first resistance, you're in a space where you have a little bit more freedom to direct your needle. and that's a relatively safer space around this area. All right, so let's pull the camera out so we can get a full face look. So with the superficial technique, it's important that you do massage the patient out before they leave, and also let them know that this area will probably take about 3 to 4 weeks for the filler to settle. Otherwise, they will ask you, why is my temple so lumpy? Okay. Okay. And of course, this is an Asian preference, because for Caucasians, some definition in this area is not a bad thing. But for most of my Asian clientele, when we have too much lateral canthal hollow with a pinch look, it's aging to them. And of course, you have to pick your patients. So maybe just with different ethnicities, everyone will want a different level of contouring. But of course, the application is the same. It's just the amount of product that you want to use. So for this side, I used the 1 full syringe of RHA2. When I'm looking at her face, I wanted to see if I'm actually able to lift this part. Because remember when I was showing her photo on the screen, the deeper fat compartment of buccal fat, this is the temporal extension of buccal fat, and it goes down this way reaching forward. This is the body of the buccal fat, and also on the border of the parotid going downwards, and then it goes around, which is the pterygoid portion. So when you have a buccal fat in that shape, sometimes that deeper fat compartment is actually quite easy to pick out, because you see that separation of back of the fat and the front of the fat. And a lot of times when people have fat displacement moving forward, you should look at these areas. And when you, of course, for example, CK4 filling, mesenteric ligament, when you fill that area, it creates a lift for that same reason. Again, turn your face that way. Sorry, close your eyes. And she does have more hollow on this side, but we'll do 1 syringe. 1, 2, 3. Oh, I got lucky today. Most of the time in these areas, there's always some bit of bleeding involved. Okay, lifting always helps. Pull back, drop a little bit, pinch again, moving the cannula forward, aspirate. And you can see this hollow over here, so I'm actually going to redirect forward. And it's actually quite easy to figure out if you're either in between the fascia or you're above the muscle. When you're above the muscle, you can go all the way towards the lateral canthus, beyond the borderline of the bone. And, sorry, let me focus here for a second. Yeah. But if you're actually in between the fascia, you will not be able to pass that bony ridge. You'll feel strong resistance. Okay. I keep my finger on top so I know how much I've injected relative to that space. Breathe. Okay. And also in this area, because your temporalis is actually part of the muscle that when you chew, that gets activated. When the patient gets nervous, they get really tense. So you want to remind them to breathe. You okay? Okay. A little bit more hollow on top. Sometimes when it's difficult to go through, it's easier to actually just move the cannula back further and then advance more forward. Yep, I'm feeling resistance, so I'm gonna pull back and try again. Injecting a little bit. And that little bit of filler has given me a little bit more space. Again, move forward, aspirate, inject, move forward.
Do you find the fact that you're between fascia makes it less likely to have that venous congestion in that area?
I think if we, like today, I'm actually doing a lot. Most of the time, I don't like to do more than 2 syringes. And even if they need 3 or 4, I'll ask them to come back on another day. Just so then the recovery process is a little bit easier. Okay, just gonna massage that out. I didn't finish this syringe even though she is more hollow, but as I'm injecting, I can feel that there is more resistance and I don't want to test my luck. And it's always good when you run into that problem in your own practice, you can find another entry point, do it again, and try to reach the point that you're trying to fill. Okay, sit up for me. I think that's a really nice improvement. Actually, I have 0.2 left. I'm actually just gonna deposit into the deep medial cheek fat compartment. So I like to put my finger here and see how much hollowness there is. And often you will feel that there is almost a triangular space where it's just hollow. And that's how you know that's where you should be. I would start laterally, 1, 2, 3. Thank you. This is a sensitive area, so breathe. And I'm really going deep, and this is where I am. Pull back. Okay. I want to cushion the space so then the filler has a place to go. Okay, sit up for me. I think that's a nice correction of the tear trough. Okay, lean back, close your eyes. Okay, 1, 2, 3. Okay. Thank you. Thank you. Deep medial cheek fat. Nope, I'm too superficial. See that? When I lift my needle and it looks like this, not the right space. Pull back and do it again. Okay. Pain? Okay. You should see a little bit more fat pad lifting as I'm lifting again. So let's feel that. Pinch. Okay. And I'm going to aspirate and slowly deposit. It's more the deep medial cheek fat, sort of touching the soup, yeah, because that's your soup and then your deep medial cheek fat, they're closely connected together. Sometimes I don't like to go too high up because then when the patient moves, sometimes fillers show through. Not with the RHA2 though, I don't think, because of the stretchability, it's a nice result. But then from my own experience, I feel like the deep medial cheek fat is an easier space to fill with less risk of mistake. Okay, and you can look at the camera. And that's today's presentation. Thank you.